me, because I had to register. Then I registered.
3, 2, 1. Recording is started, sir.
Good evening, everyone, and let us begin the much-awaited masterclass by Dr. Abha Majumdar today evening on the clinical utility of AMH for prediction of age of menopause and assessment of the functional ovarian reserve. But please allow me to express my deepest gratitude to Dr. Abha for taking all the pains and doing all the hard work in planning and executing these masterclasses. Every Thursday evening, 7 to 8, we engage in a discussion on a very, very relevant topic, which is important for our daily practice. So I would like all of you to join the WhatsApp group as well, in case you want to follow the masterclasses, which are like pearls of wisdom for all of us. Over to you, Abha ma'am.
Thank you, Tejashri. Thank you. Yes, I truly agree that it is pearls of wisdom, not only for all of you, but for me also, because it gives me an opportunity to read again. And making these slides is like painting something for me. So it's a very, very loved process, which I like to do. And in this process, I sometimes ask all of you what is new and how can we proceed. So, I was given this topic that AMH is a predictor of fertility. Sorry for the typing mistake. Predictor of fertility and menopause. So let's answer this question. Is it really a predictor of fertility and menopause? So I'm putting a question to you. Now, there is a woman with, and I want all of you to answer in the chat box. There is a woman who has a AMH of 0.4 nanogram per ml, and she's still cycling. I mean, she does have cycles. Her basal FSH is 18 and her estradiol is 80 on day 2. Her basal FSH is 13 and estradiol is 80. And her basal FSH is 10 and her estradiol is 80. I want all of you to write in the chat box, what do you think, which patient the AMH, it is equal in all, but which patient will respond best to ovulation stimulation out of these 3? Write in the chat box. We'll see the answers later on. 1, 2, or 3. Then I give you another question. AMH 0.4 nanogram. She's got menstrual cycles of 26 to 28 days. She has menstrual cycles of 23 to 25 days. And she has menstrual cycles of 35 to 45 days. Who is the worst out of these in terms of ovulation stimulation? A, B, C. Please write your answers in the chat box. I thought a lot about these questions and I've put them up for us to understand that is AMH alone a predictor or we have to see other things along with it. Then I go to the third question. AMH again 0.4 nanogram per ml and she's 31 years, she's 36 years and she's 41 years. Who will have the best prognosis in terms of controlled ovarian stimulation, or whatever you want to say, A, B, C, the capital A, B, C. So you're going to put your answers in the chat box. I already see 47 answers in the chat box. I love it. And I love this enthusiasm because it took me quite some time to, formulate this slide. And I thought, let's start working right away on it and see that which one. So AMH is same in all, but there are certain other things which make that woman a better responder or a poorer responder. Now I'll start with my question that is AMH a predictor of fecundability? So this was in 2012. I took an article, 2012 was the start when AMH articles started pouring out because AMH was available to us from around 2007 and 8 onwards. And even our first publication when Ruma was my PG, we did it in 2011-12 only. Here, what did they say? Low concentration of circulating anti-Mullerian hormone is not predictive of reduced fecundability in young, healthy women. This is a prospective cohort study. And Casper P. Hagen is here. Conclusion was low AMH in healthy women in their mid-20s did not predict reduced fecundability. So if a woman in 20s come with a 1 nanogram AMH, please do not panic. Even after exclusion of women with irregular cycles, probability of conceiving was reduced in women with high AMH. So, they said high AMH with irregular cycles will have a reduced fecundability, like PCOS women who don't ovulate. But those who have a low concentration of circulating AMH and they are having regular menses, their fecundability, this is absolutely natural cycles where you've not touched them with the medicine. So don't panic. Then, and this was their observation, AMH and fecundability. And you see what the black line shows medium AMH, the yellow line is low AMH, and the red line is high AMH. Time from cessation of birth control, and they have started trying to conceive. This is cumulative proportion of women achieving a pregnancy. So with a low AMH and a medium AMH, you see they are almost running parallel, the black and the yellow line. The one with high AMH has a lower fecundity and it is taking more time. Why? Because the cycles may not be regular. The same is here. The red marks are high AMH and the black ones are medium AMH and yellow. And you see age in years from 19 to 35. All this with low AMH concentrates between within 30 years. Lots of low AMH and lots of medium AMH get pregnant. Less of high AMH get pregnant. So this was this study's observation. Now let us come to Reproductive Biomed Online 2022. Now this is one of the most sought after, highest impact journals. And here they again publish after 10 years, anti-Mullerian hormone has limited ability to predict fecundability in Chinese women, a preconception cohort study. Again, this Chinese study, which is a huge study, serum AMH levels were not associated with fecundability in Chinese women of childbearing age. Childbearing age is anything from 18 to probably 35. A suggestive association, however, was observed among women with cycle irregularity. Those who had irregular cycles, there maybe AMH levels were associated with fertility. Regular monitoring of AMH in fecundity prediction may be of limited value among healthy reproductive age Chinese women. And this was 22. And this is another study, which was in Reproductive Biomed Online 2014, which now comes out regarding effective time to pregnancy. This is a very common history, which all of us take when we are taking history, that if they got pregnant anytime, whether it was a term pregnancy, missed abortion, midterm abortion, we always ask them the effective time to pregnancy. When did you really start planning? And how much time did it take for you to get pregnant? Someone says immediately, someone says 3 months, someone says 6 months, and someone says 2 years. So here, what did they say? There is a decline of AMH concentration as age increases, but there is no relationship between AMH and effective time to pregnancy. In conclusion, our study results suggest AMH concentrations do not influence the time necessary to conceive a live-born child spontaneously, and therefore speak against determining AMH in women who are not infertile for the purpose of predicting the chances of pregnancy. Our findings are, it is only when they come with infertility, then you start thinking that is their AMH going low and will our treatment work for them. Our findings are concordant with previous reports describing AMH as a quantitative but not qualitative marker of ovarian function, which means, I mean, even with low AMH, the time to pregnancy could be 1 month, and even with normal AMH, it could be same. And high AMH, if the cycles are regular and she's ovulating, then it would be the same. So it is not a qualitative marker of ovarian function that does therefore not reflect a woman's ability to become pregnant. And when we see time to pregnancy, this is the graph which has been given over here, where you see the AMH concentration in the vertical bar, which is 1.53, 4.5, 7. As the AMH goes higher, the pregnancy effective time becomes lower and lower. All the pregnancies are scattered between an AMH of almost undetectable to 45, and they can all get pregnant. I wouldn't say undetectable, but it is 0.0 on the bar. So again, then you know what happened? I was challenged in my department by one of my consultants, and she said she's read articles that AMH also has a role in oocyte quality in women with advanced age. So I went into literature again and I found this article. This is an open access article and this is in Nature. Nature is a very reputed journal with a very high impact factor. So what did this say? And open access journals are available to everyone to read. AMH has no role in predicting oocyte quality in women with advanced stage undergoing IVF-XC cycles. Now, what is this study? It says that AMH had a limited role in predicting in vitro embryo development potential and had no role in predicting the in vivo embryo developmental potential, suggesting that in women with advanced age, AMH should not be used as a marker of oocyte quality. So if AMH is low, her reserve will be low, her quantitative cohort will be low of antral follicles, but not the quality. This study supports the view that the accumulation of top embryos via multiple oocyte retrieval times is a good strategy for the treatment of women with advanced age, because we know that they could have aneuploidy, but quality is not affected. Then there, I found another article again, even later than that, in November 22, where this was in Fertility, Sterility, and that said, analyzing the association of anti-Mullerian hormone level with blastocyst euploidy rate. Does AMH predict oocyte quality again? Conclusion was AMH level was not predictive of the rate of euploid blastocyst in IVF PGTA cycles in this retrospective cohort. So they said whether euploid or no euploid, it was equal with low AMH and normal AMH. And why this is very important, this data will help us clinicians to counsel our patients with low AMH. Age is clearly related to blastocyst and euploidy rate, not AMH levels. So where I gave the first question that AMH is 0.4, but the girl is 31, there it will not indicate that the aneuploidy rate is going to be high. A low AMH level does not predict the likelihood of increased aneuploidy in human blastocyst and should be considered important when counseling younger patients with low AMH. So I thought this was all so important for us, for me too, to learn. And hence, what did I find? AMH is not a predictor of fertility, nor for effective time to pregnancy, and nor of quality of oocytes in vivo or vitro fertilization. So my first question has been answered, that it is not a predictor of fertility, effective time to pregnancy, or quality of oocytes. Now we come to the second question, menopause. Association of AMH to menopause. Now, anti-Mullerian hormone, follicle stimulating hormone, and antral follicle count, and the risk of menopause within 5 years. This study was, what was it? I have to remove this bar. You can read it. It is 2017, I think. And the main outcome measure was that they were looking at the probability of menopause within 5 years based on AMH, FSH, and AFC all together. So they found that mean age 43 at the time of AMH, FSH, and AFC assessment. At 45 to 49 years, if the AMH is almost undetectable, then they had probability of more than 60% to get menopausal within 5 years. 1/3 of women with no or just one AFC had menopause within 5 years. So undetectable AMH at 45 to 49 years, more than 60% probability they will get menopausal in 5 years. If you do AFC, no AFC seen, or just one AFC seen, menopause within 5 years. Both low and high FSH had greater odds of menopause than intermediate concentrations. So conclusion is the ability to predict onset of menopause was improved with any of the 3 menopausal markers in addition to age. AMH concentrations were more closely associated with menopause than AFC or FSH. Now here another AMH, a predictor of menopause in PCOS. This was Minot's study, prediction of age at menopause in women with polycystic ovarian syndrome. And then we look at the other spectrum of AMH, that if the AMH is very high and the woman has PCOS, does the menopause age change? And these findings provide the insight that, as reflected through significantly higher average levels of AMH in PCOS women, their reproductive lifespan could be 2 years longer than their normal ovulatory counterparts. So if it is very high, then maybe it is 2 years more than their normal ovulatory counterparts. And if it is low, then it has to be really very low to predict that menopause will happen within the next 5 years. So this was a very nice article, and I loved when I read it. So I brought the gist of the article. This is role of AMH in prediction of menopause. Overall, I'm reading the conclusion to you. Overall, while ovarian reserve markers, including AMH, are unmistakably related to age at menopause, they are insufficiently precise to inform on an individual's journey of ovarian aging. The use of ovarian reserve markers for long-term prediction could therefore either lead to a false sense of security or unnecessary alarm. So long-term predictions are very difficult to do with ovarian reserve markers. Say you do a ovarian reserve marker and at 28 you find it is low, you cannot make a long-term conclusion that she's going to have early menopause or late menopause. So please don't panic if you find low AMH in women who are young. And if she's not tried to conceive, she's come to you first time for consultation, a preconception counseling, don't scare her. And if she's come with unexplained infertility, having tried, please find out what is the sexual contact history. That is more important in women with unexplained infertility. Say when you find an endometriotic cyst, you find a male factor, you find anything non-ovulatory, pelvic factor, you know that there is infertility. You don't have to do much. It is mainly the unexplained infertile women where you get very perturbed with a low AMH and you rush them to IVF specialist. But if they just come with unexplained infertility, please find out if they are having proper sexual contacts. Just asking is not enough. Put them on the examination table. Try to do a PVPS. That will give you an answer whether the woman has any type of restrictions in a vaginal examination or a speculum examination. And you'll find that a lot of these women have less sexual contacts. So having said that, we are using AMH so extensively, even in the PCOS adolescent symposium, which we heard in the evening, AMH came out as a marker to differentiate between POI and PCOS. So what is AMH a marker for? This is our question. And AMH estimation is essential prior to enrollment in IUI and IVF to predict ovarian reserve to individualize ovarian stimulation. This is the foremost indication for doing an AMH estimation whenever you want to use ovarian stimulation. So it is not only IUI, IVF, even identification of PCOS or high responder ovulatory women, when we are trying to stimulate them. For ovulation induction also, it is important to know the AMH so that we don't lead them to hyperstimulation. Then it is a important marker as ovarian reserve marker in women over 35 with unexplained infertility lasting for more than 4 years. So if a woman is over 35 and she's had unexplained infertility for more than 4 years, that means they are having active sexual intercourse for more than 4 years, then it is an important ovarian reserve marker. AMH is also used for women concerned about delaying childbearing. Nowadays, a lot of young women come for a counseling that I am 30, but I don't want to have a child for another 5, 8, 10 years because I have career options or professional priorities. Their AMH could be used to allay her concerns about delaying childbearing. Because if it is already very low, then we know that, she might lose her ovarian reserve by the time she decides to have a baby. Then AMH is important in diagnosis and management of ovarian tumors such as granulosa cell and virilizing Sertoli Leydig cell tumor. In granulosa cells, we have found a level of more than 1,000 nanograms also. And the moment you remove granulosa cell, it comes down rolling to almost zero. And then again, we can do it after oophorectomy to know how well we have treated the ovarian tumor. And then it is also important to assess ovarian tissue loss after surgery or chemotherapy. So you're doing ovarian surgery. Here, I feel estimating the AMH for these young girls in reproductive age is important to know how well we've been able to preserve the ovary or how much we've lost. On an average, we lose almost 40% of ovarian reserve on surgery which is done for endometriosis for cyst which is larger than 4 centimeters, and even after chemotherapy to see how much is the reserve left. Now we get on to our own article, which when Ruma was a PG, we did it together. And this was published in Journal of Human Reproductive Sciences in 2012. Anti-Mullerian hormone cutoff values for predicting poor ovarian reserve to exogenous ovarian stimulation in IVF. So the conclusion was AMH fares better than the age and FSH in predicting the overall ovarian response and poor response, though it cannot be the absolute predictor of a non-responder status. We found a level of 2 picomoles, which is like, I would say, if we convert it into nanograms, 2 picomoles should maybe be 0.1 nanogram, is discriminatory for poor response. Yet we said that if we start refusing patients below 2 picomoles, the facility of IVF, in every 10 patients, we will lose 1 patient who would have responded with this. So I'll come to a very nice statement given later that no patient should be refused using her own oocytes with whatever AMH she has if she's still menstruating and her FSH has not gone into the POI level. So this is with Norbert Glitcher, and this is a very big name. Live birth chances in women with extremely low anti-Mullerian hormone levels. Look at the low hormonal levels which they've seen to determine whether women with extremely low serum AMH level of less than 0.1 to 0.4 nanogram still demonstrate live birth potential with IVF, and whether such potential is age dependent. So this is what their background was, that they looked at these levels at different ages. The result was they took a mean age of 40 plus minus 4 years, baseline FSH of 15 plus minus 11. So how much is 11? 15 is like 26 also, an AMH of 0.2 plus minus 0.1, which comes to 0.1 to 0.4. 128 women underwent 254 cycles, 20 clinical pregnancies, which means 7.9 per cycle start and 15.6 cumulative. Because if there are 254 IVF cycles in 128 women, so one woman underwent more than 2 cycles mostly. 70 women less than 42 years had 16 clinical pregnancies, which resulted in 10 deliveries. The rest aborted, 13.3, and 58 patients of more than 42 had 4 clinical pregnancies, which resulted in 2 deliveries, 3.4. So there was a statistical difference, a p-value of 0.03 when women were less than 42 years or more than 42 years with the same AMH. So less than 42 had a higher delivery rate with a significant p-value versus that of age, which was more than 42. So same AMH in 2 different age groups will work differently, but even at a level of 0.1, less than 0.1, we do not refuse till FSH is 25, 26. Conclusion was with extremely low serum AMH level, moderate but reasonable pregnancy and live birth rates are still possible. Extremely low AMH levels do not seem to represent an appropriate marker for withholding fertility treatment, means IVF or whatever you want to do. So if they are even extremely low, please try fertility treatment with their own oocytes and you will get a substantial pregnancy rate. I would very honestly say that so many IVF centers may have a 15, 20, 25% pregnancy rate even for younger women. Here they did less than 42 and more than 42, and they had a substantial pregnancy rate. So live birth rate after IVF ICSI in women with low and extremely low AMH, an age-matched control study. Now here they also matched the ages. Let's see what happens. Here, there was outcome of IVF ICSI in low and extremely low AMH levels in different age groups by comparing live birth rate in age-matched control. So they took 30 for 30, 35 for 35, and 40. No significant difference between live birth rate in extremely low AMH and low AMH. So extremely low was less than 0.5 and low was less than 1. There was no significant difference when they matched age-matched controls. Live birth rate was 30.4 with normal AMH and 14 0.7 with AMH less than 1 nanogram with a significant p-value. So if AMH was normal, the live birth rate was like 30, but if AMH was low, then it was 14. It was half of it with a significant p-value. So if we look at normal and low, there is a difference. But if it is extremely low or low, in age-matched controls, there is no difference. 40 for 40 and 30 for 30. Live birth rate significantly higher in women less than 35 and of 35 to 40 years with normal AMH compared to live birth rate in the same age groups with low AMH. So in the same age group with low AMH, is it 18.6 and 13.3, whereas in those who have a high AMH, it is 33.2 and 31.2. So these are less than 35 and 35 to 40. And the other one was age match image is low. Pregnancy rate, if same, whether the girl is 25 years old, 35 years old, or 40 years old. So conclusion was no difference in outcome of IVF between patients with low and extremely low AMH level in age matched controls compared to low AMH in the same age group. Age is important in determining prognosis of IVF in patients with low levels of AMH. So these are such important studies which give us so much of serious thought. And then this is a meta-analysis which was published again in Human Reproduction Update, one of the highest impact value journal. And here, if you see, the diamond of controlling all studies was just in the center. So the predictive accuracy of AMH for live birth after ART, a systematic review and meta-analysis of the literature. So they've taken various AMH levels and seen the live birth rate in them. Weak association of live births in IVF, So next is, I can't read the first line, I'm sorry, because there is a big meeting being recorded, printed right over there, but decision making in stimulation protocols. Now, this was again in 2014, where before that, we used to use individualization of controlled ovarian stimulation by values of FSH, and AMH was not available. But once AMH became available, then AFC and AMH became important markers for individualization of controlled ovarian stimulation. And what we see is that if the ovarian reserve is high, we expect a high response. Main objective is to minimize. This is 2014. So remember, at that time, Paul Deveroy in 2012 had just given out the concept of OHSS free clinic, where he did an antagonist protocol, agonist trigger, and segmented the cycle. But before that, it was not there. So all these studies were before that era when we started segmenting. Main objective was to minimize OHSS risk, and GnRH antagonist protocol was taken for this, and minimal FSH stimulation was given. When we found AMH in the middle, expected normal response, then main objective was to maximize success rate, and standard treatment was given. When we found expected poor response, main objective was to minimize treatment burden. So GnRH antagonist protocol with maximal FSH stimulation was given. And these are the AFC and AMH values. So they considered 1 as low. Poseidon came up much later than this. Now I want to show you something very interesting. Look at this diagram. Now, these are follicles, right? These are primordial, this is primary and secondary. Early antral. What can the ultrasound see? Only maybe the early antral and the pre-ovulatory. What is the AMH production from the early antral? Highest. From the antral, after that. And from the pre-ovulatory, least. So we know in an ovulatory cycle, if we do a AMH when a dominant follicle is there, we might get a lesser AMH levels. But however, this is there always in a cycle. Even at in the mid-central and antral would be there, which would secrete AMH. In ultrasound, what happens is you can only see once the antrum is formed, whether the antrum is 2 millimeter or it is 9 millimeter. Whereas those which are primary, secondary follicles, which are making AMH, you see there is some AMH coming from this secondary follicle also. This is the AMH coming, which you cannot see in ultrasound. Ultrasound sees less. AMH goes deeper to dig into these also and collect the AMH levels from this. So that way AMH looks better. AMH may be considered as deeper and more sensitive probe to define ovarian reserve compared to AFC. I'll tell you another very interesting thing. What happens, the true biology, exposure, and laboratory. If you see AMH value is 1.5. So this is AMH. All right. Now, this is the biology which says that AMH should be 1.5. Now, here it comes as, oh, sorry. Now, the moment you go on source, three sources, one is exposure. Has the patient been exposed to oral contraceptive pills for more than 3 months or 6 months? Because after 3 months, the AMH may drop a little. After 6 months, it may drop more. There was also a study which said which vitamin D, if it is deficient, AMH may turn out to be lower. So exposure to what has the patient faced before we are doing an AMH? And third thing is laboratory. You leave the AMH blood sample on the desk, on the be lower. If you leave it in the fridge at -19, it will be different. And if you do it same day, it would be different. So the laboratory has so much source of variability. If you see here, it goes much more. Exposure will increase or decrease the AMH this much. But if the laboratory also makes error, it can make a 1.5 AMH appear 0.5 or as much as 2.5. So these are the variations in AMH which may still be there because a lot of centers still do not do AMH on the same day and they leave AMH to be done on maybe once a week or 2 times a week or even 3 times a week. So that laboratory condition and whether the patient has been exposed to any type of drug, like not just oral contraceptive pills. These days, Dynogest is very commonly given. Progestogens are given. So if she's been exposed, her AMH could vary by lower or higher levels. So having said that, at present, due to the low accuracy of other ovarian reserve tests, in pregnancy prediction, exclusion of patients other than based on female age is not to be supported. So female age is the most accurate thing which supports occurrence of pregnancy. Low AMH or low FC should not be a criteria to refuse IVF with self-oocytes. It only should be age, and maybe age more than 45 is one cutoff where we would say that with self-oocytes, even if the AMH is detectable, there is a very rare chance of getting pregnant. I have had a couple of patients who came with a very nice AMH at 47 years of age. They made 12, 13 oocytes. No blastocyst conversion happened in them. And after to conclude, I from the women's biology. AMH appears most reliable marker presently to diagnose PCOS, POI or POF, and endocrine secreting ovarian tumors, as well as determine change in ovarian reserve post-surgery and post-chemotherapy. AMH is possibly better in efficacy to AFC for ovarian reserve prediction because the secretion of this also stems from secondary follicles which have not developed an antrum and cannot be seen by ultrasound. Low AMH concentration is not predictive of lowered fecundability. It is age is more important here, and how many years have passed since she's been trying is more important here. And AMH levels are not related to effective time to pregnancy in natural pregnancies. So if a woman has not looked for fertility treatment and she's got naturally pregnant within 2-3 months of trying, you can retrospectively do a AMH and confirm this finding that she did have a very low AMH, but it took her 2 months to get pregnant. The use of AMH in ovarian reserve prediction has enabled us to develop individualized controlled ovarian stimulation for IVF to optimize cycle outcome. This is the most important use of assessing AMH. that not only in IVF, in IUI, and even in ovulation, induction, in PCOS patients, in POI patients, all of them. Low AMH has poor association with live birth rate in IVF alone. Along with age, it has a very important predictive value, but not alone. Low AMH levels should not be used to refuse women from IVF with self-oocytes unless they are of high age. So this is all I have to say. The talk is finished. And as last time I did, I brought a live lesson to you for today also. We'll go for the chat session after that, or we can start with the chat session and later on I'll do the live lesson. Oh, I got
Sure,
so
ma'am.
Lesson first,
questions.
please.
Lovely.
So,
Lovely.
should we start with the
So
questions,
see,
ma'am?
yeah, yes.
Thank you so much for an elaborate presentation. And I think the take-home message for all the consultants who are not practicing IVF specifically, but infertility, is that if the AMH of a patient is low, you need not panic and scare the patient. There are many other factors that we have to take into consideration before we deny her treatment for conception. So,
Send her for IVF, correct. We can just make her try. They're not tried. You know, there's so many people. Yeah, sorry. Yeah, continue, Tejashri. Sorry.
Yeah, so I think let's move to the first question, ma'am. The first question is, should we get AMH in all infertile patients as an initial investigation?
Yeah, if you're trying to see if she's if you are taking her for IVF for male factor, or you're taking her for IVF for severe endometriosis or tubal blocks, you are going to stimulate her. You have to predict the doses, so you will do a AMH. It is only unexplained infertility if the woman is young and she's just tried 1 year and come to you. Cycles are regular. You don't need a AMH. You have to just make sure that she's trying enough, she's she's having sexual contact during the fertile period. And I love to do a postcoital test, even though it should not have a predictive value in deciding IUI, IVF, anything. But it is of clinical importance to know whether they are having proper intercourse, whether the penetration is deep enough, and whether sperms are depositing in the mucus. And it also gives you an added advantage of seeing the health of the cervix. I mean, there are so many patients who come to me who've undergone 3 IVF cycles, and I ask them, did you ever have a pap smear? They say, what is pap smear? No counseling is done for pap smear. No cervical inspection is done. So, you know, it's very important that I do all this and don't let her panic, even if her AMH is 1 nanogram or 0.8 nanogram, if she's not tried before or she's tried very inadequately.
So I think, ma'am, in an infertile patient, if you're consulting for the first time, only if her cycles are irregular and you are suspecting that the irregular cycles may not be because of PCOS, then you must advise the AMH to find out what her her
If the
reserve is like.
irregular cycles are there, that is a very important unexplained infertility of more than 4 years, woman's age more than 35, it a must do AMH. Same way, irregular cycles, AMH is very important because you will be able to, like in the afternoon, I was happy Ruma said you identify POI from PCOS. So many girls who are little obese, round-faced, and you see, oh, irregular cycle, she must be PCOS, and you find she's POI.
Surprised to see a low AMH.
Yeah.
The second question is, ma'am, what is the effect of OC pills on AMH? So I think that you have
reduces in 3 months, it reduces little bit. In 6 months, I haven't brought those slides, it reduces 50% AMH value reduces if they are on 6 months or more of OC pills.
Yeah, ma'am. So next question is, what is your protocol of choice in extremely low AMH in young and advanced age women?
Ma'am, just a second. Ma'am, can I please ask something related to what you said? 50%.
Yeah, sure, Nisha. Please go ahead.
Hi, ma'am. Hi, ma'am. Nisha here. Sorry, ma'am. I have a bad network, so the camera is not on.
Okay, no worries. Just ask the question.
I think, ma'am, when you said that the after OC pills, the AMH value is reduced. So I just want you to clarify here that maybe it is just a temporary thing. When we stop the OC pills,
So do not estimate AMH.
Yes.
In a patient who's on OC pills or who's just stopped it a cycle ago. Give her some time and the AMH will bounce back. Very good, Nisha, for bringing this up, that it is a temporary phenomena and it will bounce back
Yes, ma'am.
once you have stopped and you've given 1 month of time and then reassess the AMH.
Yes, ma'am. Thank you, ma'am. Sorry to disturb you.
No, it's very good. I want you to disturb. If you don't ask questions, then all this mehnat of mine goes wasted.
No, ma'am. It's really great of you, and we are learning so much from this. Thank you so much. Dr. Tejshri, please go ahead.
Yeah, thank you, Dr. Nisha. That was a valuable input. Ma'am, Dr. Haritha wants to know what is your protocol of choice in extremely low AMH young and advanced age patients?
You tell us, Tejashri, what do we do when we get a AMH of 0.1, 0.2, or 0.3? We take patients,
So
we don't refuse anyone, and we take them for self-oocytes. Age is a very important message here again. If women are over 42 with a low AMH, I normally counsel them that your chances of pregnancy would be very low. But what is our protocol? You tell us.
So in younger patients with low AMH, we go ahead with a pre-treatment with a estrogen. We start with to make a good cohort, and then we do counsel them for a protocol which is Stim
or Bistim.
Or Bistim also, now that we are going through that. And advanced stage patients, we like to add a little LH source also. So that would be additional thing in advanced stage patients with low AMH.
Yeah, even in young ones, a few clinicians like to add LH in low AMH, but yes, advanced stage LH is more important.
We certainly need to add.
Yeah.
Ma'am, Dr. Manjusha wants to know whether DHEAS helps to improve AMH or oocyte quality.
I think DHEAS should be considered more as a nutritional agent. Like in the afternoon when I spoke on PCOS adolescents, inositol does improve the metabolic risk of PCOS, but it is a nutritional agent. Same way, DHEAS is used as a nutritional agent. And how can it improve AMH or oocyte quality? It can just maybe improve a little the cohort, not even the cohort, the collection of oocytes may go up because it's got an androgenic quality. And we know that protocols are there where androgen gels are given for almost 20 days with the OCP in a prior cycle, or in a long agonist protocol, androgens are given for 5 days, and then we start stimulation. I mean, a lot of people are there who do it. I don't use so much of androgen. But DHEAS, most of the studies say that we need better quality studies. We don't have any clear-cut answers for DHEAS, which will improve AMH. Oocyte quality पे तो कोई असर होगा ही नहीं. It is only whether it can increase the cohort, because androgen sensitizes the follicles to the FSH coming from pituitary, and this is a very weak androgen.
Dr. Ayushi is asking whether low AMH with no AFC seen on the ultrasound, should we still not deny IVF to these patients if there's no AFC?
I think, Ayushi, you missed out my first slide. If there is low AMH with no AFC and she has got no menstruation, there is no reason that we would do IVF, especially if we do her FSH and E2 and we find that FSH is really high. So if there is low AMH, no AFC, and yet she's having regular menstruation, there's something wrong somewhere. And such a girl, if she's in her 30s, should not be denied IVF if she's still having menstruation and her FSH is in reasonable value of 13, 14, 15, 16, 17 also. What do you say? Others can comment on this. What do you
Ma'am
say?
Shweta here, I want to add, my question was, so if we have like an unmarried female soon to get married and her FSH, like she's a cat POF, so how do we counsel her? Like, but there is a chance of spontaneous ovulation, so but she needs like E plus P for her periods, so how do we counsel her?
So listen, Shweta, I very recently got a patient who came with me with a 0.01 nanogram AMH, and her FSH was high. High means it was like 15, 16. She wanted oocyte cryopreservation. I told her, you are not fit for oocyte cryopreservation because we will not get more than 1 or 2 mature oocytes, which we will be able to freeze. And if you want a live birth out of this activity of yours, you're not doing it only for the heck of doing it, then you need at least 12 to 15 oocytes, which we will have to stimulate you maybe 10 times to get those 12 to 15 oocytes. You know what happened? She took out a paper, and I'm not taking the name, one of you were there, who stimulated her and who preserved one oocyte for her. And then she comes to me that I want, and I said, yeah. And she showed me her papers, and I said, this is what is going to happen. In every cycle, maybe we will get one oocyte. You are not a fit candidate for oocyte preservation. So it is very important to counsel them against and tell them that, see, your childbearing is going to happen whenever. And with this type of AMH and AFC, you are young. It is very difficult. You can't get married in one day. You can't find a partner. So please forget that you would be able to have your own child. You will need, I mean, with your own egg, you will have to need a oocyte donor. So, you have to tell her with a lot of empathy. You have to counsel her softly. I mean, there are girls, there is one of my residents who came with this, and I had to counsel her alag se baith ke, that see, please don't get so disturbed. At least you will carry your partner's child and you will be the gestational mother. But with this AMH and this FSH and with no menstruation, like you said, where you have to give her estrogen and progesterone for withdrawal bleeding, it is best to tell them reality, though you can tell them slowly, not at the first go. All right?
Okay, thank you, ma'am.
Oocyte preservation should not be done for them because you know that you will not be able to do anything with one oocyte preserved per cycle.
Ma'am, I'm not sure. I read one article I'll be sharing in the group. So they
Okay.
said they had given Femoston for 3 to 6 cycles. For like an early POF, the FSH was in range of 30 and AMH too low. And
What is
then
Menopause? Can you just tell us
it's
what is
like
Menopause?
it's Dynogest plus estrogen. They're giving in HRT, the menopause HRT. Uh,
Okay.
I will just share the article, ma'am. But they said like after 6 months they could stimulate with letrozole and they could achieve a pregnancy. So
Okay. Maybe
let
this is
me.
Sure.
one anecdotal case.
Yeah.
So
Yeah,
we're talking
Dr.
about
Shweta
oocyte.
will look forward to your article. We would like to go
Yeah,
I
through that article
definitely
for
see
sure.
because
Please do
I was
share
asked.
on the group.
Yeah,
We have a lot
definitely.
of
When
questions
you
to
say
take, I think.
IVF, if you say oocyte cryopreservation is no
No,
for her,
no,
maybe
yes,
there is some complementary treatment which we can give her to make her respond and make her ovulate. Like
yes,
hypo patients ovulate once and they get pregnant, right? Same
yes,
way, I'm
yes.
sure that this girl must have got pregnant with some type of treatment they
You
gave her. But
mentioned
this is the anecdotal case. When we
case.
talk of oocyte cryopreservation, that is not for
No,
these
no, yes, ma'am.
girls.
Yes, thank you, ma'am. Thank you.
Ma'am, Dr. Priya
Uh,
wants to know what about females with early recruitment on day 2 with borderline AMH and the age of between 33 to 35?
Yeah, Priya, this is the problematic group. And in these patients, if you start gonadotropins, you'll find that they've got a follicle on day 6 or 7, which is dominated. Even when you start IVF, these cases worry you. And that is why Tejashree told you that we like to give estrogen in the luteal phase for at least 7 days to prevent this recruitment. So it is not only in IVF, even in other cycles, you can prevent this recruitment for girls who have a borderline AMH, who recruit early. So you prevent the recruitment and then give her stimulation with whatever you want to give, whether gonadotropins or maybe clomiphene or letrozole. So we have to prevent this premature recruitment. I'll tell you why. Because by the time she gets her menses, her FSH has risen to almost select a dominant follicle, which happens by day 5 of FSH rise. Now her dominant follicle is selected on the day of menstruation or maybe one day later. We start monitoring her from day 3 and we still find all the follicles less than 10 or 12 mm. You give her medicines and in 3 more days or 4 more days, you'll find a follicle become very big and the endometrium still lagging behind. Today we had a patient like this, Tejashree, if you remember. Day 8, her endometrium was
Right.
5.8 and she had 18 and 17 millimeter follicles.
Follicle already.
Yeah. So here the endometrium is going to be, dysynchronous with the follicular growth. I mean, follicle will rupture, endometrium will still be lagging behind because she menstruated when the follicle was already 5 day old. I mean, she should have menstruated before and the follicle should have grown for 5 days after her menstruation. So this is what happens in
I
these.
think if that is happening, we would prefer that we counsel her to begin IVF sooner than later.
Yes, that also, and we can also make her cohort better. Not only cohort better, we can stop this premature recruitment by
Selection.
giving her
Follicle.
some
Yeah.
estrogen or antagonist in the luteal phase.
Ma'am, Dr. Pratyusha wants to know, should we rule out hypo in low AMH and AFC in very young patients or in less than 35 years?
Hypo should be ruled out in all patients. I mean, you do a FSH and I mean, if patient is not menstruating for 6 months also, then you don't need a basal FSH. You just do it on any day, but she should not be on oral contraceptive pills or any type of hormonal treatment. So if she's on no hormonal treatment, you do a stat, FSH, E2, LH, and you will get an answer for hypo.
So basically, a hypo patient could have an ovarian reserve ranging from PCO range to a low AMH.
Yeah,
So
AMH would be good
hypo
in
and
such
then
cases.
yes, so hypo would have a variable range of AMH depending on what their ovaries have the ovarian reserve
But
as.
they don't generally have a high AMH, Tejashree. I've always
Yes.
seen
Yeah, generally,
High
but
AMH.
there are patients who might have low AMH within hypo as well.
low
But usually you see the picture also, AFCs are good.
0.1.
Ma'am, I think your connection is lost with us. Yeah.
Low AMH
Still
and
can't hear. Yeah.
estrogen progesterone.
Now it's better.
Huh?
Your
Now it's
connection was
better. I
lost
think
in
it must have
between.
been.
So yeah, again, unable to connect with you, ma'am. Hi, Dr. Vishal.
Yes, madam.
Yeah, I think the meeting is still on, right? I think Dr. Abha got
Yes,
disconnected from the
recording
meeting.
is still on. Yes, ma'am. Meeting is
Right.
on.
Let me just connect with her. Let me find out if she's able to connect back to us.
Okay, ma'am.
Yeah, give me a minute. So I request all the participants to patiently wait for a minute. Ma'am is just trying to join back and she is really wanting to share the last life lessons slide. So let's just wait for a minute for her. Yeah. So Dr. Abha is still trying to join back the class. Some issue with her connection. So let us till then discuss the questions that are in the chat box. So young patient with very low AMH, 0.01 nanograms per ml and infertility should be advised IUI or IVF. So that's a good question, because if it is very low, we would first like to stimulate her and see what her response is at a certain dose of gonadotropin. We would prefer to ask her to try naturally if she hasn't tried before she's come to us, and then take a call about IUI. IVF certainly would be, option when things haven't worked for a month or two. So if 2 cycles of IUI, 1 or 2, probably 2 cycles of IUI, and then we ask her to move on to IVF. And till then, we also know how she's responding to those gonadotropins which we've given for IUI. So first step, certainly, if she's young, we would prefer that we should do 1 or 2 cycles of IUI. She can just might conceive with that.
What do you prefer, letrozole or clomiphene?
Ma'am, we do IUIs with gonadotropins in low reserve patients. So we do use, recombinant or humo. Either of them, according to the affordability of the patient. Preferably, if they can afford, we use recombinant. But we do IUIs with gonadotropins.
And while deciding between IUI versus IVF, we also need to look at the age of the patient, the duration of infertility.
Yeah, so it was about young patients. I think that's so. Ma'am, so Bhavani, would you want to take this question? That these days many women are aware of AMH. So how to counsel such young age women with low AMH?
These young girls have to be assured, like ma'am said, that there's so much evidence that AMH is not a predictor of fertility. So they have to be reassured. But yes, if there is low AMH at a very young age, she's not married and she's not planning to get married in the near future, then she can be encouraged for oocyte cryopreservation also. But also counsel simultaneously that she may not need those oocytes, as she may conceive naturally itself.
Good evening, ma'am. Can you hear me? Ma'am?
Yes, you
Can you see me now? Can you see me
Yeah,
now?
Dr. Abha is here. Yeah. Yes, ma'am.
Yeah, you can see me now. I'm so sorry about this. I used Acha, and my screen is still there.
No, ma'am. Screen sharing has
So
stopped.
who is
So you'll have
sharing
to
the
reshare
screen?
the
It says you cannot use, you can't start screen share while the other participant is sharing.
I think now you'll be able to share the screen, ma'am.
Okay. Share screen. All right. So a lot of questions, but I wanted to share this. So I did this drawing myself. And so I thought, let me share this. This is a very common, I'm now a old person. So I give this advice to a lot of my youngsters. All the questions finished? Any question left?
So there are a few more questions, ma'am.
So we can take them if you are ready to stay after 8. Is it all right in task team?
Yes, madam.
Dr. Dave?
Yes, madam.
Okay. So what are the other questions left?
So ma'am, I think somebody wanted to know about your opinion on the PRP and stem cell therapy use in low
I
reserve
wish we
patients.
have some clear-cut answers. I would surely use PRP and stem cell. There are a lot of studies coming out on this. Some say yes, some say no. There is still so much of controversy, just like scratch in cases of RIF or implantation failure. So I don't use PRP unless I'm absolutely like devastated what to do types. So I maybe have used in my lifetime in 5 or 6 patients PRP, and a few of them did get pregnant, few of them did not. So I have very little take on PRP because I somehow am very evidence-based, and I feel that empirical medicine, especially when we are injecting your blood into the uterine cavity, could give you infection or other type of problems, and that's why I'm very wary about it. But I'm sure a lot of studies are coming, and people use PRP in ovary, use PRP in the endometrium, and stem cell. Well, Bhavani, you can tell them about the recent study we've started on stem cells for Asherman's.
We are doing a study on Asherman's and refractory
After
refractory
getting
Asherman's and refractory thin endometrium, where we are deriving the stem cells from the Wharton's jelly of the umbilical cord. So most of the studies that have been done have been from stem cell derived from the bone marrow, which is an invasive procedure. Whereas here we are, there are very few studies from China, 3 studies, which have used umbilical cord stem cells. So we are using that technique because umbilical cord is otherwise thrown away. It's a non-invasive method of getting the stem cells. So we are instilling the stem cells subendometrially under hysteroscopic guidance, and then we'll see how the endometrium responds to the treatment.
We've got funding from this from our hospital's research committee, and the ethics committee has approved use of these stem cells in only 10 patients. And we had to get insurance done for these 10 patients, that if any adverse reaction happens due to the stem cell therapy, that insurance will take care of these patients, because we cannot charge anything for this stem cell injection. So, we go very much by ethical guidelines and all. So that's why on PRP, I would not be able to give my opinion. I mean, you all would be using it much more than me.
Ma'am, just 2 questions before we move to your slide. Can you please elaborate on the luteal phase use of antagonist to prevent dyssynchrony in the next cycle in follicular size?
Yeah, that's a good thing, but we don't use
Dr.
it.
Rachna.
Yeah, Rachna, it is very good, because, see, the moment we use antagonist, the FSH-LH will get suppressed and there will be no follicular recruitment. But we have to give it for 5 days, because normally recruitment happens in the second half of the luteal phase. Say after 7 days, when the progesterone levels start declining and the estrogen levels decline, and here the FSH starts getting secreted with the corpus luteum demise. So if we give antagonist for 5 days, but then it is an injection, more expensive, and hence a lot of studies have not come up on antagonist. I like it, but I don't use it much, because I feel that injection lagega and cost, I don't use any injections in my luteal support. I mean, this is the biggest blessing patients have when they come to me, because I promise them that I will not use any injections except when there is recurrent IVF failure and implantation failure. Then sometimes I resort to low molecular weight heparin, but injectable progesterone and all is away from me. So same way, luteal antagonist would be very good. I would encourage you to do a short cohort study comparing Progenova and antagonist in alternative patients, and see where your cohort gets better in the same AMH patients. It would be very nice to know about it.
Right,
When to
ma'am.
start is
Ma'am, Dr. Yukti wants
uh,
to know whether we can make a diagnosis of POI or POF solely on the basis of serum AMH levels.
Yukti, it is best not to use one investigation solely, because I've shown you how AMH can differ due to various circumstances, including laboratory and whatever exposure has happened of the patient. So it is best to use AFC also with AMH, and if she is menstruating, the FSH E2 levels, everything together, plus her cycle length, how delayed or early her cycles come, everything together would give you a better diagnosis of PI or POF, not solely AMH level. It has to be included. FSH, E2, cycle length, age, everything has to be included.
Ma'am, just the last question for today. In low AMH patients, would you prefer a long agonist or antagonist protocol?
If antagonist doesn't make a good cohort, I would love to go for a long agonist protocol.
But the first choice would be antagonist.
Antagonist, after using something to make a cohort.
Right, ma'am. Ma'am, that's all for today in the chat box questions.
Okay, today we had lots of questions, because AMH is such a thing. which always gives us all a little worry that everyone is getting AMH done. And I always see patients' paper and say, so this is AMH scare which has brought you to me. Because, you know, the moment a general gynecologist does the AMH and finds it below 1.2 or around 1, they really get panicky. So my life lesson
Ma'am,
today.
one more thing.
हाँ बोलो बोलो हाँ.
No, ma'am, one more thing I wanted you to highlight was, ma'am, post surgery, ma'am, when do you recommend doing AMH?
After 3
Because
months.
if
After 3 months. AMH reduces significantly because of the cautery which you've used, because of charring, because of desiccation, and the AMH will bounce back after 3 to 6 months. So AMH should not be done. And you know, best is also for IVF. Don't start it immediately after you've done a surgery. Give the patient's ovary a little time to recover, maybe 1 or 2 cycles. And in those 1 or 2 cycles, please let the patient try to conceive herself rather than putting her on long GnRH agonist, you know, to sort of say whatever endometriosis is left, we want that to be killed also. Because I've seen stimulation after long GnRH agonist, if we've given it for 3 cycles, stimulation becomes also very difficult. Long agonist protocol is very good, which you start in the luteal phase and you stimulate, you get an excellent cohort. But if you give a prolonged GnRH agonist for 2-3 months post-surgery, doing IVF then makes it even more difficult to stimulate the follicles to grow. So please do not, if you're going to do IVF, give her a month's gap for the ovary to recover its health, for vascularization to come back, for all the cautery related side effects to go away, and give her a month and then do IVF, or give her 2 months and do IVF. Anything else?
That's all, ma'am.
Do you agree about this? I want everyone's opinion also. You all are doing IVF. You know more than me. So do you think that we should do IVF immediately after endometriotic surgery or give her 1 or 2 months to recover? What is your opinion? Nisha, Shweta, you're all there.
Ma'am, I usually, Nisha here, ma'am, I usually try to, if all looks good, endometriotic cyst, even if I want to remove it, I usually create embryos before going ahead with surgery. And
Okay.
if
That
I
is
have
a
done
very
surgery,
good option. But if you have to do it later on, then will you give a
then I
gap?
will some time. Yeah, give it a
Give
gap.
them. Right. So everyone agrees with this. Now I'm coming to my life lesson. Please
Yes, ma'am.
understand, life is like a rainbow. We are all doctors. Live it in parallel lines, not in segments. ऐसा नहीं होना चाहिए एजुकेशन खत्म हो जाएगा फिर हम अब कैरियर देख रहे हैं. जब कैरियर अच्छे से बन जाएगा तब हम फैमिली के साथ टाइम स्पेंड करेंगे. तो उसके बाद हम हॉबीज देखेंगे. फिर हम अपना सोशल सर्कल बनाएंगे. एंड सोशल रिस्पॉन्सिबिलिटी तो जब हम बुढ़े हो जाएंगे तब हम करेंगे कि हम कुछ सोसाइटी के लिए कर रहे हैं. और रिलीजन तो मतलब बिल्कुल बुढ़े हो जाएंगे तो हम दिन रात पूजा करेंगे. सो दिस शुड नॉट बी द वे लाइफ शुड बी स्पेंट. इट शुड बी स्पेंट लाइक दिस. Yes, one segment may be broader at times and you give lesser time to the other segments, but everything of this rainbow, all the 7 things I've written here, should go all together. This is all my life
Ma'am,
lesson for all of you today.
thank you so much. And I think this is on behalf of all the participants that I would like to thank you from the bottom of my heart. Having so many participants today, nearing 200 and almost 100 till the last line that you spoke, all speaks about your popularity and how endlessly we just want to keep on listening to you. But I
And
think every day has an end. So I think let us finish the meeting only to begin next Thursday, 7 p.m. So I will be posting the WhatsApp group link in all the groups so that people can join and follow the masterclasses.
thank you, everybody, for joining me. And you make my preparation worthwhile because I do spend a week or 10 days in thinking how to bring this forward. And then I go into the internet and I collect references. So it gives me a lot of food for thought also. Thank you.
Thank you, ma'am. Thank you so much
thank
for
you, excellent, ma'am.
Thank you, ma'am.
Thank you.
Thank you.
Thank you. Okay, Intas, Vishal, Dave,
Thank
thank
you,
you
madam.
as usual for
Thank you.
giving us this platform. I'm so happy that we spend zero money on this, whatever. I don't know whether you spend anything on making this platform, but it goes a long way to say how interested you are in sort of helping in education endeavors. Thank you. Thank you.
you.
Okay, Sangeeta Milap, I can see you sitting there. It's lovely to see you. Sangeeta was 1 year junior to me, and she's a very brave girl. Lots of stories with her. Okay, bye Tejashri, Bhavani,
Bye
and
bye. Good
everyone.
night, ma'am. Thank you so much. Thanks.
Good night, ma'am. Bye, ma'am.